Sorry.
Puts you guys on the spot too. So the topic for this suicide prevention table is how our bias can be a barrier to suicide prevention and having discussions about suicide. And then a second part is an intervention appropriate for all veterans, no matter their risk level. Do you guys feel comfortable talking about suicide with patients? You're getting there? With the increased requirements for screening, especially with the Columbia at admission and discharge, I think just the more people are doing it, we're kind of forced to become more comfortable with it. So I think that's helped people who were not comfortable before. I can say before I came up to mental health, I avoided the topic as much as possible. That's the truth. When I was in primary care and we had to call patients who were discharged from 4B for any mental health reason, especially suicide, I sat there and I hoped they wouldn't pick up the phone. Maybe I was scared of saying the wrong thing, scared of making the situation worse. I know on inpatient it was always reassuring to know that somebody's coming behind me and will have eyes on that patient and that you know that somebody else is going to be there. But when somebody's at home or going home, that might be the last message they got was one from you, and so you just want to make sure you're not doing further harm. It's important to know that asking about suicide is not going to plant thoughts in anybody's head. Have you ever had an experience with a patient around suicide that you can recall that didn't go well or that went really well?
Especially this last year, I
Behavioral emergency.
had a
Please
lot of
respond to
positive
4A,
screens.
room
Okay.
4A30.
Being able to have that open conversation,
Behavioral
like, a little
emergency.
bit talking about it,
Please respond to
is absolutely normal, and
4A,
it's not
room
taboo. I think the more
4A30.
comfortable that we are as the healthcare professional,
Behavioral
that the
emergency.
more comfortable they become,
Please
and will
respond to
actually tell you
4A,
things
room
versus like, you just sense this
4A30.
rigidness and they don't want to speak. So
Yeah, if it feels like you're checking a box, they're probably not going to want to open up to you. I've seen people take the approach, well, I have to ask you this, so let's just do it. And even if the patient maybe would have said yes otherwise, at that point, they're probably not going to reveal, something that happened to them or that they've been thinking about. So definitely approach is important. Have you ever had a patient respond badly to being asked? Maybe they became angry, maybe they laughed at the question. Have you had patients not respond?
Yeah.
Well, do you kind of have a go-to when patients don't take the question seriously?
yeah, my approach has been, we have some of our discharges, we do a repeat Columbia just to verify, and they'll be, oh, I don't want to answer this, and I already told you at the beginning, and I think just reiterating that suicide is a huge epidemic, and so especially with our veteran population, so we take it very seriously. I care about you, and that's why I'm asking. I want to make sure that you're okay before
Absolutely, yeah.
we
That
take the next step.
we don't want anybody to fall through the cracks, and with this, we ask because we care, absolutely. I think that can kind of change somebody's perspective, and especially sometimes the situation when a person walked into the hospital before they were admitted, maybe they got some devastating news. And so things change, and that's why we do screen so frequently, even within one admission. So I think hearing that can be impactful for veterans. I know sometimes our past experiences with suicide, maybe outside of work, some of our religious beliefs or cultural beliefs can impact how we approach the topic. So it's just important sometimes to kind of reflect on those things before we approach the topic. Brenda was telling us that you guys now kind of have a huddle where you share your intentions of why you're at work every day?
I'm night shift, so
Oh,
we
okay.
get excluded from a bunch of us. That may be true for days, I don't know, but.
Hey, Chad.
I didn't know that was a thing, no.
I mean, I just think it sounds wonderful, because I mean, we all get burnt out, especially with some of our frequent flyers. And I know I pretty much left your maid because I was burnt out on detox patients. And I know that I kind of stopped caring as much as I should have for them. Their outcome really wasn't important. I just knew that see you in a couple weeks. And just that kind of self-reflection can
How
be.
good that you realize that though, because that takes a lot of work too.
It can, and I mean, at the VA, there's lots of opportunities if you're ever looking for a different position. But, yeah, just I guess sometimes we have to stay in our job. So yeah, that self-actualization can help out. So yeah, I looked at like a meta-analysis, and I just want to make sure I cover some of those big points. Education in nursing school, I know I went back for my bachelor's a couple years ago, and it wasn't, suicide, mental health wasn't part of the core curriculum unless you took like a specialized class. So I think nursing schools could be doing a better job with the topic. I know it being a national priority for the VA, we have a lot of information coming in, we try to share.
Was the number still at 22 a day?
Nope, so that number has been inaccurate for quite a while, actually. And they separated out the data between active duty veterans, National Guard veterans, and veterans no longer serving. They now say the number is 17 a day for veterans. But
That's excluding active duty.
yep, and National Guard,
National Guard,
that
right.
would not be eligible for VA care. They try to use different statistics to kind of bring that home, just because to be presenting that information and try to divide it out by veterans and active duty people, it kind of gets lost. But yeah, it's definitely still a problem. We've made small gains, but definitely need to do more. The other thing that was identified was that, so you know somebody is at risk for suicide, what can I do about it? So, I mean, you know what to do on your unit. If somebody's identified at risk who maybe wasn't at the start of your shift, you're comfortable. But an intervention that you could talk to any patient about could be their access to lethal means. Lethal means could be a firearm, poison to include their medication, suffocation. It could be self-cutting injury. It's really hard to limit somebody's complete access to something that they could stab or cut themselves with at home, something that they could hang themselves with at home. But medications and firearms are two things that definitely we can all make a little bit safer. So safe storage of both of those items is important. Our medications that we prescribe all have the locks on the top, the safeties. And we hand out gun locks to anybody, as many as they want. I think we gave somebody over 25 before. There's a lot of people who have a lot of guns in our catchment area. And that's fine, that's our culture. But so we do things like that. When we know a patient's at high risk for overdose, we give them 7-day supplies of their meds at a time. We encourage everyone to use a lock. And then based on their risk level, we encourage kind of extra steps. Maybe we hope everybody stores their firearm locked with the ammunition separate, but maybe they could give their key to a loved one to hold on to. For the people at highest risk with firearms, we encourage them to temporarily store their firearm off-site. It's important to use the word temporary, that we do identify that hopefully your crisis is limited, and when you're in a better place, you'll be able to manage your own firearms again. With medications, if people have a caregiver or a family member, we ask them to help with medication management for a time being. We do know that suicide crisis is often time limited. The 3 circles are a study of suicide attempt survivors. 25% said that between their impulse and their action was less than 5 minutes. So if, say their firearm is locked, say the key's in the garage, anything to build in some time and distance to interrupt that impulse can save lives. We encourage people to keep a photograph of a loved one, an animal, by their firearm, maybe keep it in their car if their plan was to sit in their car. We encourage people to keep the crisis line number wherever their impulse might be leading them. We know that 80% of people who attempt suicide and live will not go on to die by suicide later, so help is available. People can live a more productive life, I guess, after a suicide attempt. The triangles, the red shows suicide deaths by firearm. 85 to 90% of people who attempt suicide with a firearm will die by that injury. I imagine the other 15 to 10% have some sort of lifelong injury. All other means combined, 5% will die. So if someone chooses almost any other method besides a firearm, there's a much greater chance that they will live. It's not about a political debate, it's just completely about crisis management. When I have the discussion with veterans, I try to take that stance. I give them credit for what they know. They all know firearm safety, they all know firearm storage. They've been trained, and it's something that most people take a lot of pride in. But it's kind of that crisis management, or times when we're going through rough times, maybe relapsing on alcohol or drugs, or going through a divorce, lost some loved one, when our rational thinking kind of goes out the window. And I think that somebody asked the question, well, do people get offended? Most people who are in crisis or at risk know they're at risk, and they actually appreciate the help in the conversation. I think just that approach of being open and honest and willing to listen, I think people respond to that. Do you guys have questions for me? I start talking and then I don't